Today's topic is coronary microvascular obstruction and dysfunction in MI. This is largely based on a review article in Nature published 2024 by Mattia Galli. So the scope of the problem, the mortality and morbidity in acute MI has drastically improved since last 50 years due to CCUs, aspirin, thrombolysis, newer antiplatelets, statins, and anti-failure drugs. However, the past decade has shown not very significant improvement in mortality trends in US, and so to find newer avenues of improving this even after primary PCI, we delve deep into the problem and look beyond the coronary epicardial arteries, which we already opened up, and this led to coining of the term coronary microvascular dysfunction. It is used to describe a spectrum of structural and functional abnormalities in the coronary microcirculation, leading to impaired coronary blood flow resulting in myocardial ischemia and angina. And this is not limited only to acute MI, but it is also in angina and cardiomyopathies, INOCA, MINOCA, the new terms which are coined. So despite the high success of coronary reperfusion with primary PCI, impaired myocardial reperfusion due to microvascular obstruction occurs in approximately 50% of patients following ST elevation MI. Microvascular obstruction associated with coronary microvascular dysfunction is thought to be multifactorial, including endothelial dysfunction, reperfusion injury, embolization of the thrombus distally, and intramyocardial edema and hemorrhage. Looking to coronary microcirculation, it can be broadly divided into three compartments. One is the epicardial coronary arteries, which are the large conductance artery from 5 mm to 500 microns, and these are the conductance vessels. However, they do provide only 5 to 10% of myocardium with blood flow and are just conductance vessels, and in absence of coronary artery disease or after primary PCI, when a stent is implanted with a negative FFR, the resistance to blood flow is very low in this area. It is less than 20%. Then comes the pre-arterial vessels, that is 100 to 500 microns of vessels, which are extramyocardial, and these are the major vessels where the resistance is quite high and they are very sensitive to flow and vasodilators. Then comes the small arterioles, which are less than 100 microns and have very high resting tone and are responsive to local metabolites like adenosine or this, and the capillaries are where the exchange takes place. So we can visualize the major coronary arteries on coronary angiography. However, there is no way of visualizing the microcirculation, and hence they can be assessed indirectly through measurements of coronary or myocardial blood flow and flow reserves. As we know that about 70% of oxygen extraction is at rest, and when there is need of extra oxygen during exercise, it can only be provided by vasodilating the distal vessels and hyperemia, which can increase the coronary blood flow and increase the oxygen supply to the myocardium. So resting supply is normal, then the most important thing would be the hyperemic blood flow. So coronary microvascular dysfunction can result due to functional and or structural alteration, the relative importance of which seems to vary across clinical settings. So, and both can coexist. So now, what are the terms? There are multiple terms used in past few years, and multiple trials have been done, and the focus from the major epicardial coronary arteries to the microcirculation has shifted. So CMD or CMVO, coronary microvascular dysfunction or coronary microvascular obstruction and dysfunction. This is an umbrella term comprises of no reflow, microvascular obstruction, intramyocardial hematoma and myocardial vascular injury. No reflow was the earliest term coined way back in 1968, and this is using coronary angiography where there is no partial or delayed antegrade flow, which is quantified by TIMI flow, TIMI frame count or myocardial blood score. Using microscopy, there are lack of marker of flow such as carbon black microspheres or thioplasmin. However, it does not provide much information about pathophysiology, and though very specific, the sensitivity is quite low. If we quantify microvascular obstruction by using coronary angiography TIMI flow, it is hardly 3% of the patients who have MVO. However, if we go by more sophisticated mechanisms, the prevalence is quite high, which we'll refer later. Now, microvascular obstruction using cardiac MRI with gadolinium based contrast agent, contrast enhanced infarct area with contrast void infarct co, and the microscopic using microscopy we can see distal atherosclerotic embolization, plugging of circulating blood cell, microvascular thrombus formation, extravascular compression in form of intercellular edema and intramyocardial hematoma. IMH using CMR without contrast agent, hypointense infarct core on T2 weight imaging. It is irreversible destruction of capillaries with loss of interendothelial cell junctions and extravasation of erythrocytes into myocardium. MVI is a general term for microvascular damage after ischemia reperfusion. Ischemia reperfusion injury is a general term of tissue damage following ischemia and then reperfusion. It is not limited to coronary vasculature. It can occur in cerebral or peripheral vessels also. So now, what are the causes of CMVO? The pathophysiology. The most important three things which we can describe is ischemia reperfusion, distal embolization and individual susceptibility. Now, ischemia reperfusion, it is most important. The ischemia is even after ischemic damage, after 90 minutes, endothelial cells and distal capillary source changes. Endothelial cell initially shows endothelial blebs followed by myocardial swelling and followed by endothelial protrusion and leakage of from junctional cells, which leads to extravasation of erythrocytes into the intercellular space, intercellular edema, and after that there is activation of endothelial cell with adhesion of inflammatory cells, which leads to plugging of the capillaries. Now, distal embolization. This is probably the most important after reperfusion, and distal embolization occurs. We are well aware that most of the strokes in carotid arteries are due to distal embolization of a plaque material. In coronary also a similar phenomena takes place, and distal embolization does occur with either thrombolysis or recanalization with stenting primary PCA. Now, most of these are platelet and neutrophil aggregates which plug in the smaller microvascular and releases pro-inflammatory cytotoxic and vasoconstrictive molecules. And this obstructive emboli in the microcirculation, when they constitute more than 50% of the capillaries in an area, the perfusion defect is seen in the area on either myocardial contrast imaging or cardiac MR. Individually susceptibility of the patients, genetics polymorphisms does play a role. There are genes which determine the reactivity to adenosine, and polyallelic genes in which males are more susceptible to CMVO rather than females. The traditional risk factors, that is diabetes and acute hyperglycemia, hypercholesterolemia and hypertension, smoking, these all traditional risk factors are not only the risk factors for large epicardial coronary atherosclerosis, but similar changes occurring in small vessels and are more susceptible to CMVO in the presence of this. Again, acute hyperglycemia can cause changes in the metabolism and lead to free fatty acid generation during ischemia, which can lead to more CMVO. Lack of preconditioning, if there are no collaterals and no preconditioning, then probably the chances of CMVO are more. So this is the non-ischemic capillaries. With ischemia there is endothelial swelling, and with reperfusion there is breakage of endothelial cells and causing irreversible damage, producing massive reactive oxygen species and diffuse endothelial swelling, blebs, gaps, rupture of endothelial cells and destabilization of interendothelial cell junctions, which leads to increased vascular permeability, edema and interstitial edema and intramyocardial hemorrhage. So now what are the predictors of CMVO? Which patients tend to have more microvascular obstruction after primary PCA? So prolonged time from symptom onset to reperfusion, and there is no rocket science here. We have always known that time is muscle, but more than 90 minutes if the ischemia is persistent, even after you open up, there is a lots of damage at the capillary levels which cannot be retrieved by just opening the conductance vessels. So opening up the coronary artery, coronary lesion and a negative FFR does not mean that the myocardium will be perfused 100%. So time is muscle adage applies here also. Diabetes, advanced age, male sex, absence of pre-infarction angina, that is there is no preconditioning. These all are factors which are related to higher CMVO. Higher Kilip class meaning higher infarct burden, high thrombotic plaque burden, plaque rupture at culprit site. So the plaque morphology also plays a role, and if it is an ulcerated plaque with lot of inflammation, there are more chances of distal embolization of this activated inflammatory plaques, and anti-OL MI is probably related to more CMVO. So now incidence of CMVO, how many patients of STEMI have CMVO, and this is defined as once you open up the conductance vessel, still you have no reperfusion to the myocardium, that is known as CMVO, and that also can be staged into stratas 1, 2, 3, but we won't be discussing that. So using coronary angio, no reflow, that is TIMI anything less than TIMI 3 flow, only 2.7% of STEMI patients have CMVO. However, when we use cardiac MRI as gold standard and see microvascular obstruction is present in about 54.9% of patients with angiographic optimal flow, and of which IMH is present in 34 to 40% of patients. That is, irreversible damage is present in 34% of patients. So various trials have quoted the prevalence between 10 and 67% of patients with STEMI treated patients treated with primary PCI. So we'll go to diagnosis and quantification. So diagnosis of CMVO can be done by TIMI flow grade, myocardial burst rate, TIMI frame count. The traditional methods: incomplete segment resolution on ECG, on echocardiography we can see myocardial contrast echocardiography, increased level of cardiac biomarkers, microcirculatory resistance and cardiac magnetic resonance imaging. So what are the trials of MVO in AMIs? This is a data of 7 trials which were taken and they were pulled and analysis was made. So these were trials from 2004 to 2011, and extent of MVO was present in about 2.5 to 2.3, and number of MVO present was about 37 to 77%. Days to MVO assessment varied from 3 to 5 days, and clinical follow-up was done for a median of 1 year. And microvascular, the results were that microvascular obstruction in patients with and without adverse event at 1 year of clinical follow-up, time from study entry, median microvascular obstruction percentage LV myocardial mass was greater in patients with versus without all-cause mortality. Hospitalization and heart failure also correlated with microvascular obstruction. However, reinfarction did not correlate with microvascular obstruction. So if you have more segments of microvascular obstruction, then the chances of all-cause mortality and hospitalization for heart failure increases, but not reinfarction. The prognostic implications: if we consider MVO present or absent and the percentage of LV infarcted less than 25%, the infarct size less than 25% and more than 25%. If we see the 4 scales where microvascular obstruction and infarct size was less than 25%, microvascular obstruction was absent and infarct size is less than 25%. They had the best survival rates at 2.5 years. And if we consider the second line, microvascular obstruction absent and infarct size more than 25%, then the mortality was almost double. And if we see the third line, microvascular obstruction present and infarct size less than 25%. Here, if we compare with this, the infarct size both is less than 25%. But if microvascular obstruction is present, its prognosis is even worse than if microvascular obstruction is present and infarct size is more than 25%. So microvascular obstruction is a better predictor of mortality than infarct size, and it is additive to infarct size in consideration of long-term mortality. So every 5% increase in infarct size leads to a 19% increase in all-cause death at 1 year. However, just 1% increase in CMVO leads to 14% increase in all-cause at 1 year, and both are independent predictors. Now, modalities of diagnosis and quantification. So myocardial contrast imaging, it is easily available, can be done in both in cath, it is validated, can be done in OPD basis, can be validated, it can be done even before we start the primary angioplasty. It is the ratio of baseline area at risk to myocardial contrast imaging no reflow, and if it is more than 25%, a diagnosis of microvascular obstruction or no reperfusion post PCI can be made. This is a representative image of contrast imaging in patients with an acute anti-AL MI. Left side, the panel A shows good contrast enhancement with injection of sonicated contrast agent into left coronary artery. Was observed at the area of risk here. While in contrast, in the substantial amount of contrast defects are seen here even after successful opening of culprit vessels, and the patient had no reflow on myocardial contrast imaging. Cardiac MRI is the gold standard, can precisely quantify extent of CMVO or infarct size, and when it can be done plain cardiac MR also, or a gadolinium enhanced cardiac magnetic resonance imaging. Now when gadolinium enhanced CMR, dark hypointense score as seen here, and areas of hyper enhancement, that is suggestive of microvascular obstruction, and that can be early or late, and there can be intramyocardial hematoma, which is a poor prognostic factor and suggests that irreversible damage has been done. It is high cost, there are time delays, limited availability, claustrophobia can cause problem. The time delay can occur, so that if we want to take a patient for primary PCI, then it would be available. So there is no, the cardiac MR is usually done between 3 to 5 days to assess CMVO, and then it can give a long-term prognosis, but for acute it may not be very helpful. IMA on MRI, focal eccentric hypo low attenuation, suggestive of irreversible damage, found in about 40% of patients with primary PCI. Now, cardiac MR is the gold standard. However, newer cath lab techniques have been developed with thermodilution and pressure measurements to diagnose MVO, and IMR is one of the most important which we have used. So the correlation between IMR and cardiac MR is about 2/3. 1/3 of the patients differ on this. However, both are independent predictors and can be used independently or together. So thermodilution and Doppler based methods, of which coronary flow reserve, index of microvascular resistance IMR, are most important, and they have been validated, and there is 4-fold increase in mortality if IMR is positive, that is it is less than 40, and in CFR, if the vasodilatory reserve is less than 2, then it is suggestive of microvascular resistance. However, it has limited prognostic data. Doppler indices, HMR is the most validated thing, and 6-fold increase in mortality if HMR is positive and the value is less than 3. So the most used is IMR, that is index of microcirculatory resistance. It is an invasive wire based measure of coronary vascular function. Pressure wire system is used to measure both coronary pressure and flow. Because the pressure sensor can also act as a thermistor, flow can be estimated by using thermodilution technique to calculate mean transit time of room temperature saline injected down the coronary artery. The minimal achievable resistance or IMR is quantified by measuring distal coronary pressure and multiplying it by transit time during maximal hyperemia, typically induced by with intravenous adenosine. So once your plasty is performed, you can perform IMR using the pressure and thermodilution wire. And IMR more than 40 is the only independent predictor of infarct size more than 25% on CMR at 6 months, whereas TIMI flow grade, myocardial perfusion grade, ST segment resolution, coronary flow reserve and M are not. So how do we do IMR? This is the resting status where the basal resistant index is measured and you do a hyperemic pressure and flow resistance and you calculate the ratio of it. It is a thermodilution using saline injections. 3 saline injections are given and a ratio of all the 3 is taken. If there is a variation of more than 30%, we have to do the test again. Room temperature saline is injected, a guiding is put at the mouth, well engaged, pressure wire is taken and pressure is zeroed at the tip of the guiding and put distal, about 5 mm distal to the distalmost portion of LAD and about 7-8 mm into the circumflex. Room temperature saline is injected in 3 boluses to obtain reproducible and consistent thermodilution curves from which mean transit time is calculated. Distal coronary pressure is measured by pressure wire and it is a wedge pressure which is to be taken, but it is difficult, and so considering it as 0, IMR is distal pressure into the mean transit time, whereas where the unit of IMR is mmHg per second. And this is repeated with hyperemia. So rest IMR and hyperemic IMR is taken. There is a novel factor, MRR, microvascular resistance reserve, and this is specific to microvascular. Ratio of pure microvascular at rest to MMR during hyperemia, that MMR is equal to CFR into FFR, and no correction for epicardial conductance is required, which is in this. However, IMR requires a Young's correction for epicardial conduction. However, this is not yet validated. Now, what we are familiar with is coronary angio-based assessment, TIMI flow. So, TIMI flow less than TIMI 3, which is normal TIMI flow, has a 3-fold increase of mortality in future, and it is very sensitive for microvascular obstruction. However, the very specific for microvascular obstruction, however sensitivity is quite low. So corrected TIMI frame count and myocardial blast score are taken as even more sensitive factors than TIMI flow grade, and this is very easily available and all cardiologists do it day in and day out. So this is an easy way to diagnose MVO. However, the incidence of MVO and pathophysiology cannot be done by this. So now AI has joined in, and from this computational IMR angio, NH-IMR angio and cube methods are tried so that we can get microvascular resistance without doing any further pressure wire or thermodilution techniques. IMR angio is the ratio of number of frames taken from contrast dye to flow from proximal to distal reference vessel under hyperemia. The acquisition rate determines the time taken from the dye from proximal to distal area, and the quantity flow ratio is the pressure difference. This is validated in patients with MI with the conventional IMR, and hence this can provide a CMVO IMR without using pressure wires or thermodilution techniques. There is another NHIMR which does not use hyperemia, and patient with hemodynamic instability can undergo NHIMR angio. So this can be done in our cath lab provided the software is installed. So this is the central illustration: coronary microvascular dysfunction pathophysiology and assessment with conventional and novel methods. So we can assess with coronary angiographic flow pressure wire indices, CMR, and angiographic derived IMR. The pros of this are high accuracy in predicting IMR more than 40 units, no need for pressure wire, easily available at the time of primary PCI. Initial validation has been done. The cons are further validation is required, and accuracy is depending on the learning curve. So the key points: CMVO is fairly common in patients with STEMI and is associated with poor prognosis. Prompt epicardial revascularization by timely PCI is the most effective strategy for treatment and prevention of CMVO, but is also a relevant and confounding factor for CMVO. Increasing understanding of the underlying mechanisms and availability of more tools for prompt and precise identification of patients with high risk of CMVO will be important for design of future trials. Thank you.